Welcome to today's Clear Health Quality Institute webinar on telemedicine's role in combating the opioid epidemic. My name is Lauren Newell, and I am CHQI's Director of Sales and Marketing. Before we begin, I'd like to go over a few housekeeping items. Today's presentation will be recorded, and an email will be sent next week to all individuals who registered containing a link to the recording. Second, to minimize noise and distraction, all attendees' phones are muted. However, if you have a question or comment during the presentation, we encourage you to submit it using the chat box section on the lower right side of the webinar portal. We will address these questions at the conclusion of the webinar. Today's discussion will be moderated by Dr. Peter Yellowlees, Vice Chair for Faculty Development and Professor of Psychiatry, University of California, Davis, and immediate past president of the American Telemedicine Association. After completing his medical training in London, Dr. Yellowlees worked in Australia for 20 years before coming to UC Davis to continue his research in telemedicine and e-health. He has an international reputation in telemedicine and long-distance health and education delivery. He has a number of research interests and is presently working on projects involving electronic record implementation, physician health, internet email, and video consultation services. He has published 3 books and 200 scientific articles and book chapters, and has received $12 million in research grants to date. Today's presenters are Jonathan Evans, President and CEO of Novotel, and Ann Woodbury, Executive Director, Advocates for Opioid Recovery. Jonathan has been employed in the behavioral health care field for over 30 years. His career began at Hammett Institute for Behavioral Health. During his tenure, he worked in many departments, including emergency crisis intervention, outpatient therapy, Director of Diagnostic and Evaluation Center, and the Director of the Adult Division. John left Hammett IBH in 1993 to become the founding president and CEO of Safe Harbor Behavioral Health, which provided intensive outpatient services to patients with serious mental illness and to provide 24-hour-a-day crisis intervention services. Jonathan initiated a telepsychiatry program at Safe Harbor Behavioral Health 10 years ago through a SAMHSA grant. As a result of the successful implementation and patient outcomes, Jonathan founded Novotel Psychiatry in 2014, providing telepsychiatric coverage in multiple states in partnership with providers. Novotel currently provides service in 9 states with over 30 clinicians and enjoys strategic partnerships with the Council for Behavioral Health and Patrick Kennedy. Our next presenter is Ann Woodbury. In June 2016, Ann Woodbury joined forces with former Speaker Newt Gingrich, former Congressman Patrick J. Kennedy, and political analyst Van Jones to form Advocates for Opioid Recovery. As Executive Director, Ann leads AOR's efforts to break down barriers to evidence-based treatment through education, research, and advocacy. AOR's advocacy campaigns have been recognized with multiple industry awards, including Best Healthcare Campaign of the Year by Reagan's PR Daily. Ann previously worked with Senator Gingrich for 12 years, with whom she co-authored Saving Lives and Saving Money, Transforming Health and Healthcare. Now, a brief overview of Clear Health Quality Institute, the host of today's webinar. CHQI was founded in 2017. Our telemedicine accreditation program was launched in April of this year and is the only telemedicine accreditation program recognized by the American Telemedicine Association. Our organization's senior leadership has brought more than 20 healthcare accreditation programs to market. Our volunteer committee system consists of diverse stakeholders representing providers, payers, consumer advocates, and industry representatives. Our accreditation program helps to close regulatory gaps via its high fidelity standards. And finally, the CHQI seal offers consumers and other stakeholders an easy to identify confirmation of quality from an independent third-party organization. And with that, I now hand the presentation over to Jonathan Evans.
Thank you, Lauren, and I want to thank everybody for joining us, and specifically thank the Clear Health Quality Institute for organizing us well, and also say that I had the opportunity to meet with a group from CHQI and want to compliment them on the really nice structure that they have proposed for accreditation for telemedicine and telepsychiatry, and Novotel will be pursuing that accreditation because it is really so well done. So thank you to the CHQI staff for that. We thought we'd start off the webinar today with a little bit of a level set in regards to the current environment nationally, and then focus specifically on opioid addiction. But I'm sure everybody is aware that's listening that there's a significant challenge in regards to workforce, specifically in regards to shortage of psychiatrists. And this is a slide I just really picked up recently that I've included in my usual slide deck that really gives us quite a vivid snapshot of the current status of psychiatric coverage. And if you just look at the coloring in there and look at the white boxes, that's basically said indicates there's no licensed psychiatrist practicing in those counties. It really is a significant geographic footprint of lack of coverage. And we're of course very concerned about in general for psychiatry, but also in regards to the significant challenge regarding opioid addiction. If we could go to the next slide, please. Thank you. So with that, while the current situation is quite challenging, it's a bit daunting going forward. As you can see, this is a slide from the American Psychiatric Association indicating that the current workforce, while it is limited, it is aging out. If you go all the way down to the age of 50, approximately 70% of all practicing psychiatrists in this country are 50 or older. And in talking with the more tenured physicians that we work with, they're becoming more and more dissatisfied with the practice because of the immense regulatory oversight and the challenges with getting reimbursed in a sustainable manner if they are in a private practice or working in a clinic. And the immense push at the front door, including the levels of high acuity and comorbidity. I think we're really challenged to keep good clinicians working. So with that, I think we'll go to the next slide, unless there's any other comments.
So John, it's Peter Gellerlees here. I'm just going to jump in briefly, if you don't mind. Just to sort of make a couple of comments about this slide, because I think certainly in terms of a psychiatric profession, this is very crucial to this whole webinar. Obviously, as a psychiatrist myself, I'm constantly being approached by recruiters, and so the shortage of psychiatrists is really obvious from that perspective. But I think one of the opportunities we have by using telemedicine, obviously not just for treating people with opiates or addiction disorders, but more broadly with a range of mental health disorders, is we have the opportunity to potentially at least partly reverse this situation that we see on the slide by actually allowing more psychiatrists who perhaps in other situations wouldn't be working at all to start working using telepsychiatry. And by that I mean, for instance, young female psychiatrists with families who now are quite commonly, in fact, able to work from home, still look after their children, and in the past would have found it very hard to actually get work in a traditional mental health system. Equally, quite a lot of psychiatrists are now working in a sort of hybrid manner. We've talked about that in a book that I recently wrote on telepsychiatry, but looked at exactly this issue in some detail, and also looked at the issue that increasingly psychiatrists in particular are saying that it's their impression that it's actually less stressful to work using video and other technologies than it actually can be working in a traditional clinic, partly because of all of the administrative issues you're talking about just then. So I think when people listening to this webinar, they should also, at the back of their minds, constantly think about the fact that using more telemedicine is potentially, a reason for to actually increase the available psychiatric workforce.
And Dr. Ellis, I would agree, and actually our experience has mirrored exactly what you commented on, that a good portion of our employed psychiatrists are young parents who have found it to be a nice opportunity to balance being a professional and being a parent as well. In addition to that, the use of telepsychiatry is so much more efficient. For example, we have child psychiatrists that can attend to an outpatient clinic in the morning before school starts. And then when school starts, they literally click an icon on their desktop and move to say a partial day hospitalization program hundreds of miles away, attend to those children, and then come back to outpatient in a very efficient manner. So it really takes full advantage of this limited resource.
No, I think that's really important. I mean, for instance, when I work with the Indian Health Services, I don't just work with one reservation. I actually work with six reservations, and so in any one morning I might go to 2 or 3 different reservations to see patients, just depending on who needs to be seen where. And essentially, I'm working in a way that would be utterly impossible, using any other technique.
Yep.
So let's move on to the next slide now, because we've got a lot to talk about today. And if we could just bring up that next slide for everybody to see. The way we're going to run this seminar is basically by showing everybody a series of questions that, as a group, we've put together with CHQI. And so you'll see the questions we're addressing, and then we're going to try and, the 3 of us, have a fairly broad discussion around those questions. So the questions on this first slide, setting the stage, are ones that I want to ask Anne to start discussing, and then John and I will sort of jump in as we need to.
Thank you, Dr. Yaliz, and I really just want to also say thank you to Lauren and CHQI for putting together this important topic. In terms of why the issue of telemedicine and opioid use disorder are being seen as almost a comorbid condition, and I think can be really used, opioid use disorder be used to advance adoption of more telemedicine, is because when you look at, we just saw on the 2 slides previously the psychiatry limitations that are in terms of the workforce, but even less people are able to treat with opioid use disorder. So you've got the general capacity challenges, but even within the mental health profession itself. But then when you start thinking about and looking for people who are certified to deliver, an important part of opioid use disorder recovery is recovery medications. And there are a lot of barriers to providers prescribing those medications. So that is an even smaller universe of people that are able to do that, or at least prescribe all 3 of the medications that are available. Then even if they're certified, in many cases, they're limited on how many patients they can treat. So again, now you're looking at an even smaller funnel of potential providers that can treat these patients. The other reason why, if you are a provider that is trained and certified and willing to treat this type of patient, and we'll talk a little bit more about why that is such an important piece of this, is the providers that are willing to treat, because there's such a bias in this area, that how are you able to actually reach those patients? Many of these patients are in rural communities. Opioid use disorder disproportionately impacts rural America. So access is a huge issue to care for rural communities, as we know in general. But then again, as we've just talked about, the funnel is so much narrower for these types of individuals. So you put all of that together, and you start looking at what the solutions are, and telemedicine becomes an obvious place to do that, where you can hook up the providers like yourself, Dr. Yaliz, that's able to and willing to treat patients out there. The other piece I'd just say for telemedicine that I think is interesting is the justice system. Many people, unfortunately, that have mental health disorders or are living with opioid use disorder find themselves justice involved at some point or another, and treatment in the justice system is less than ideal, and access, again, getting providers that are willing to treat in these facilities is a challenge. So telemedicine also could play a big role there. In terms of,
Thank you.
So do you want to add anything on, John, before I move on to the best practice piece, or Dr. Yaliz?
I was just going to ask if John had any comments on that. I mean, I think everything you say is absolutely right.
Sure. I think specifically in regards to the last comments you made, and in regards to the criminal justice system, you're absolutely correct that there's an inordinate number of individuals, both psychiatric and certainly drug dependent that are in the criminal justice system. I think I did read an article indicating that the two largest psychiatric hospitals, as it were, are the LA County and Cook County Jail at this point, with more individuals in beds there that really do need treatment. Recognizing it's not an ideal place for treatment, for recovery, but the need is there. We have fortunately launched a forensic telepsychiatry program with actually a graduate of the UC Davis fellowship program there, and have found it's a little slow going, but we are starting to see some correction facilities at least start to accept telepsychiatry as an option. And again, as we talked about before, the efficiency of utilizing a very limited resource is pretty significant. Moving a physician from one facility to another is not only quite easy based on the ability to move on a computer, but also the physician doesn't have to spend a half an hour going through security protocols just to get into work. So we see it as a very viable option to get care to individuals.
Okay, so Anne, perhaps you could move on to the next question, discussing best practice treatment for opioid use disorders.
I think this is a really important question to provide context for the broader conversation, because many people don't realize the difference in treating people with opioid use disorder, or the best practice related to opioid use disorder versus other mental or physical ailments. So first of all, when you look at the best practice treatment, it's really a trifecta. First and foremost is the behavioral counseling, that access to therapy, to psychiatry, to people that are credentialed and capable of treating you. And the second piece is the social support. So, for example, communities of support online, also types housing, transportation, other types of social support. The third piece that is generally, as we know, medication is sometimes used to treat different mental health disorders. In the case of opioid use disorder, medication is a vital piece to achieve long-term recovery. It's considered by the World Health Organization, NIH, et cetera, essential to being in successful long-term recovery. And there are 3 long-term recovery medications. All are very highly regulated and require special training. And not everybody can prescribe these. So they're methadone, which you can get in an opioid treatment program in the United States. Buprenorphine and naltrexone are prescribed through provider offices, either specialists or primary care doctors. In the case of buprenorphine, you have to go through a lot of different hoops and to get that certification. But the reason why it's so important is that people that get these recovery medications are so much more likely to stay in long-term recovery than people who aren't. Not only that, but abstinence-only rehabilitation, which would basically be just the behavioral counseling and social support, and many times you hear people, I'm going to rehab. Most of the time, rehabilitation programs are not using recovery medications. In fact, it's anywhere between 20% and 50% of the behavioral counseling programs out there and the behavioral treatment programs don't use any kind of recovery medication. And here's why that's important. Because overdose death is you are such a high risk for overdoses when you are addicted to opioids. It's the leading cause of accidental deaths. There are 175 a day of general overdose deaths related to drug overdoses, but 115 of them are attributed to opioids. And this has increased four times in the last 15 years by a factor of 4. So the reason why that is because, and this is what makes opioid use different than other kinds of substance abuse, is that when you go into that detox, and I know Dr. Yellees, you could speak to this, very eloquently, I'm sure, but when you go into that detox, your body then goes into withdrawal, and you leave the maybe 30-day abstinence-only rehabilitation program, and a couple days later, where you didn't have the recovery medication, a couple days later, you take the same amount of opioids that you had been taking before, and your body can't handle it, and that's when you see overdoses. In fact, there's studies that show that you're more likely to die of an opioid overdose if you've gone into abstinence-only rehab than if you never went into that rehabilitation at all, because of what that 30-day or however many day that you're in there process does to your body. So this is an important piece of the conversation. It just really emphasizes the importance, that recovery medication piece, and as we've already talked about before, how limited we are in the number of doctors that can prescribe that. The only way we can expand access to those doctors is really using a telemedicine solution.
Mm-hmm. So thank you very much, Anne. And I must say, I think the points you make are really important. I mean, I just want to highlight, I guess, the two major sort of almost philosophical questions that you sort of really covered there. And I do that deliberately because, I mean, I'm a physician who used to treat addicts in Australia in a much more open and quite honestly easier way than I could ever do here in America. And the sort of two big philosophical issues that I think, the whole field hasn't really worked out yet. The first is are we really talking about a correctional or a health approach to people? And I think in reality, in many instances in America, the correctional approach with excessive numbers of regulations has really, unfortunately, led the way. The second philosophical issue is, do you believe in a harm minimization approach versus a total sobriety approach? And I think there's no question that the evidence is better for the harm minimization, which includes MAT very much, rather than, as Anne was saying, the total sobriety approach. And unfortunately, I think right now the field is skewed too far in both the correctional and the sobriety approaches. And from my perspective, we need to really rejig it and move it more in a health direction and in a sort of harm minimization perspective. John and Anne, what do you think about those two issues?
Well, I think it's a good point when there's consistent discussion about the standard of care and evidence-based treatment, and the comments you made are right in line with that. That if I understand, we look at the evidence that points to both of those is a more fundamental solution in regards to positive outcomes.
So that's great. Okay, and thank you very much. So we're going to move on now to the next slide, looking more about clinical practice. And I think, John, you're going to take the lead on these questions.
Yeah. So in regards to, I think we're going to move to the next slide if we could. There we go. In regards to technology being accepted, we have found this to be really a very positive point, and in the time that we've been providing telepsychiatry, that we have a protocol in regards to connectivity that's we've fine-tuned over the years. And what we have found is that our practice reflects the research that's been done by the American Psychiatric Association that has been very well accepted. We do a significant amount of patient satisfaction surveys across the clinics that we have, and with very few exceptions, we have found this to be accepted quite surprisingly by all age groups and by clinicians who have found this to be really a nice way to practice for a couple of reasons. Some we've already mentioned in regards to lifestyle and work-life balance, but also in diversity of practice. I think in the traditional model, clinicians, just by the nature of location, tend to get into a practice pattern that's pretty consistent every day. Telepsychiatry offers a unique opportunity to have really during the week different practice opportunities. For example, we have a number of psychiatrists that are in traditional outpatient clinics, but then also have an opportunity to do collaborative care with primary care physicians in primary care networks. And we have found that that leads to a real improved level of satisfaction for our clinicians. The steps that should be encouraged in regards to a successful telemedicine program, I think, are quite fundamentally and primarily regulatorily. I think everyone knows that science tends to advance much quicker than regulation and legislation, but we are well into this at this point where we do need some regulatory relief. And we'll get into that in the next slides, but the primary hurdles that we have run into in regards to having a large number of very well-trained and psychiatrists that are focused on this type of care is really getting through the licensing and the regulatory issues in regards to this modality.
So can I just jump in and first of all ask Anne, do you want to comment on any of the things on these two particular questions? Because we're actually going to go back in a minute to the prior questions and look a little bit more about the clinical practices before we move on. But Anne, any thoughts?
I agree with John in the sense of there's a lot of regulatory barriers that really need to be addressed, and I think they also contribute to some of the insurance barriers that we're going to talk about a little bit later.
Sure. And then just in terms of these barriers here, from my perspective, I mean, the evidence is really clear that patients really like working like this. That's true in telepsychiatry. It's true in the relatively few programs using telemedicine that have been used for opiate addiction. And that, so the patients are not usually really a major problem at all. They're very accepting of this. The people who do have problems still sometimes are the providers. But as John was correctly saying, that is absolutely not the case for certainly younger providers who have been brought up in a social networking world and for whom working like this is just the natural way of going. So there are, I think there are no major sort of provider barriers. I mean, the barriers are primarily regulatory at the present time. So if we can move back to the slide before, which was about clinical practice, and just look at some of those issues. Great. And so I mean, the first question here is, do we know how much telemedicine is being used for MAT in this country? And we put that question in simply because we have absolutely no idea. And we want to make it really clear that, it's very hard to find this out. There are obviously a lot of telepsychiatry being done, and the American Telemedicine Association about 18 months ago estimated that in 2016 there were over 1 million patients treated on telepsychiatry in the USA. Obviously many more consults, but 1 million individual patients. But we have no idea how many of those were receiving MAT. Now, it's quite likely that a fair number were, because quite a lot of those consults would have been done working in the way that I personally work, which is basically beaming into primary care clinics and working with primary care practitioners who often have buprenorphine licenses and who are often able to actually prescribe. And part of my role when I'm essentially consulting like that is to manage both the addiction or advise on the addiction medications, as well as manage a number of psychiatric meds, and obviously look overall at the need for therapy and any other assessment issues. So I think you'd find there's quite a number of psychiatrists are working in a way that I'm working, whether that be for private companies or for academic institutions, who are interacting with patients that are using MAT, but very few actual groups that are specifically, delivering MAT as their primary approach. If we look at the services that can be provided through telemedicine, I mean, essentially, there are two primary services, obviously direct consultations in the same way that you do a consultation for any other patient, directly and usually into a clinic, increasingly into homes. And then obviously in the homes there's another regulatory issue in terms of the prescription side of things. but equally commonly using a sort of consultation model, as I was just describing. So I think those services are fairly widely available now, and there's no doubt that there is the potential capacity for a number of people to provide MAT services into areas of need, if that could in fact become easier from a regulation perspective. Any comments, John or Anne, on any of those questions?
I was just going to add that for some of the folks on the phone, they may be interested in knowing about a program that uses telemedicine to train doctors called Project ECHO, ECHO, based out of New Mexico. And they train doctors for free based on a grant that they've gotten from the government. So if anybody on the phone is interested in becoming, getting that certification, they may want to check out that opportunity, because it's all done through the internet and through telelearning.
And just to add a little more in regards to that, and again, as far as diversification of practice, we do have a number of our psychiatrists working and collaborating with primary care clinics, really providing a whole range of consultation, from the traditional curbside consult to something even more robust if a full psychiatric evaluation is indicated. That can be done, again, directly via telemedicine and documented right on the electronic medical record of the clinic. And what that does is certainly give a primary care physician a level of comfort in regards to a path going forward. And I think, based on the numbers, this is going to be another primary solution to the supply and demand equation, is this partnership in regards to collaborative care.
So, John, I think that's a very important issue, the whole issue of using telemedicine for collaborative care and then treating patients in their primary care environment. Can you just describe a little bit about how your practitioners interact with the primary care doctors? I mean, what are the processes you use? Sure,
happy to. So maybe just a little history. One of our founding psychiatrists, Dr. Everly, was part of the COMPASS study many years ago, which was funded by CMS, and essentially it demonstrated that this type of collaborative curbside consult practice really did help meet the triple aim of improved access, improved outcomes, and lowering cost. And the model is that she would collaborate on a weekly basis with a team. They would do a case review of patient presentation and meds, and then she would give guidance to the primary care team in regards to, based on the diagnosis, comorbidity, and med panel, what would be the best psychotropic meds to add to that. And her cohort were patients with diabetes and major depression. What they found out at the end of the year is the outcomes were very positive. The depression scores improved, but so did the A1Cs. And so as a result, I'm sure many know that CMS did publish collaborative care codes that are now billable for the primary care team. And we do take that approach with some primary care networks, primarily in Minnesota at this point. And it's been extremely well received by the primary care teams, because they essentially, prior to this, didn't really have access to psychiatric care, and were really, with good intentions, doing the best they could. So this, again, it's a really efficient manner to get people to care and to improve outcomes.
Yeah, and I would agree. I mean, I certainly, in my own practice, that's exactly what happens. And so every patient that I see, the patient at the end of the time with me will go and run around the clinic and will find that either their primary care physician or someone who knows them to come in and spend the last sort of 5 or 10 minutes of the consult with me, so that we then communicate directly with the patient and their primary care provider, and that I mean, that certainly works extremely well. The patients love it because they see two doctors talking. They really, they feel very much listened to. In fact, I frequently ask the patients to summarize the conversation I've had with them for their own doctors. And so I then am really working as the third person in that triad. And and the whole thing works very well. And as you correctly say, the primary care physicians can bill for their time, which is totally appropriate. And they can bill a consult for that, and obviously, we do the same. So really, for me, this is the perfect form of collaborative care, and this is a model that does work very well for patients with substance use disorders. And I've been using this model now for a number of years. Even though I'm not doing the prescribing, all of the prescribing and ordering gets done within the primary care environment.
Correct. Yep.
Anne, any comments on any of these issues from your perspective?
No, I think you guys covered it.
Okay, well, let's now move on. Let's jump 2 slides and move on to the regulatory barriers, which I'm quite sure a lot of people are here to unfortunately listen to and hear about, because this is a super confusing area and a very difficult area. Unfortunately, Anne is right up to date on all of this, so I'm going to throw these questions in your direction, Anne. Thank you.
Sure, and I invite John as well, since he has lived experience, so they say, in terms of understanding how this is hindering practice. But Advocates for Opioid Recovery is very much focused on breaking down barriers, and unfortunately so many of them are the result of government policies or private policies as well in getting access to evidence-based treatment. Firstly, and I kind of divide this into 2 pieces. One is related specifically to telemedicine, and the other is related to opioid treatment. On the opioid treatment part, we covered a little bit of this, but there are a tremendous amount of limitations that are unique to opioid use disorder in terms of who can prescribe and where you can prescribe. So, for example, methadone, which has been around for decades, and is all 3 of these medications have unique characteristics that make them appropriate for some patients, not appropriate for others. So it's not a one-size-fits-all proposition, but methadone can only be treated in opioid treatment programs. And it is a amazingly regulated area where in some states they may only have 2 or 3 opioid treatment programs, and in Wyoming they have 0. It's very state-based, based on where they want to give their licenses, and it's just been a real challenge to get those programs opened in some states. On the buprenorphine, you have to go through a number of trainings to be able to prescribe buprenorphine. Up until last year, year and a half ago, only people who went full-time MDs could prescribe buprenorphine if they went through the treatment program. You could not prescribe it if you were a nurse practitioner or physician assistant. Additionally, you had a limit on how many patients you could treat. You could only treat 100 patients. So under the Trump administration, they raised that to 275. They also extended it to nurse practitioners and physicians assistants temporarily. So one of the things that the current legislation in the House is going to potentially do is extend that permanently. But there is a cap, which is, when you think about it, a very unusual thing. We don't cap prescriptions on anything, even regular opioids. So although anybody, any doctor, any prescriber can prescribe an opioid, you have all these limitations on actually prescribing an opioid treatment recovery medication. And have limits on that. So it's a real challenge, and one that I know at Advocates for Opioid Recovery, we strongly believe that those barriers are discriminatory. You wouldn't have those for any other kind of disease. It's particular, diabetes, heart disease, it would be unheard of. But because this particular population is there's so much bias against it, these limitations have been able to continue. On the telemedicine side, there's 2 different kinds of barriers. One is the inability to prescribe medications across state lines because of state licensing, issues. But more important for this particular conversation, I think, is the Ryan Haight Act, which was passed in 2008 and basically requires an in-person consultation before a controlled substance is prescribed. And these recovery medications are also considered to be controlled substances. So they have very, very narrow, limited exceptions about a facility being a DEA-registered facility, for example. But basically, the limitations and the risk associated, there's so much unclarity about, around this act that it's really thwarting access for people that even psychiatrists, doctors who want to do these things, won't do it because they just can't comply with that in-person requirement. So the other piece of this is that in the Ryan Haight Act, there was a provision that talked about defining and activating a, quote, special registration that would allow physicians and nurse practitioners to prescribe a recovery medication via telemedicine with much less restrictions. But in the last 10 years, there's been no movement out of the DEA to actually put out what those rules would be. And so that is a big bone of contention with those of us that are trying to advance telemedicine, that the DEA has not done that, even though it's in law that they need to come up with this waiver or this special designation. One of the things that's happening in the House right now, and I believe there's a bill in the Senate, although the House is further along, in the House bill, there is a provision to mandate that the DEA provide interim final regulations for the special registration within 12 months of passage. So, if that language stays in there and eventually this becomes law, it would force the DEA's hands, because all indications that we have gotten is that the DEA is probably not going to move otherwise unless they get their hand is forced by Congress. That kind of sums it up on my side.
Okay, so John, any comments?
Yeah, I could just expand a little bit on what Ann had to say. Is in recent conversations with the DEA, you're exactly right that although they've been in statute, should have written these regulations, which would open up a large number of opportunities for community mental health centers, if the regulations are written appropriately, to become certified to do this treatment. And I can tell you, in every community we're in 9 states and over 40 clinics, that the express need is significant. And there's literally not a community in this country that's not touched by this issue. On the other side of the equation, we have current physicians and physicians who want to work with us that are certified to do this care, but we do not do any of it because of the issues that Ann outlined very nicely. Our discussions with the DEA has been, our goal is literally the same. We want to decrease and eventually eliminate diversion of opioids. The most effective way, without question, to do that is to get individuals who are addicted into treatment. I don't think as Dr. Yellowlees pointed out, the correction approach, it has not demonstrated it works well at all. I don't think it will. We can't arrest that many people, and they eventually come back out. So clearly, effective treatment, and I think we have some additional tools available, is the answer. So we've been advocating. We've worked with the National Council on Behavioral Health, who's done a lot of work on the Hill regards this. I know, and organizations you work as well. I think from the treatment community, the message is clear: is we would like a path forward to be able to provide this type of care.
So that's very helpful. So I'm just going to go backwards a little bit, and just for people who are listening, I provide a little bit of extra history here, because I think it's important to understand the background to all of this, because this is a huge sticking point in terms of the provision of services for addicts with opiate problems. And before I forget, just to remind everyone, if you want to ask any questions, please do just type the question into the chat room box, and that'll go to the organizers, and I can then bring up those questions to the panel. But Ryan Haight basically was an 18-year-old man who died tragically from an overdose in February 2001. It came out after he died that he had been essentially getting opiates on the internet via a particular website called Blue Light, where he had been paying for his drugs that were given to him on the basis of answers he put into a questionnaire and were delivered from an international outside of the US pharmacy. His parents actually thought that he was spending quite a lot of money on baseball cards. Unfortunately, he wasn't. So the bottom line is the Ryan Haight Act was actually introduced, I think, with the best of intentions as a way of essentially combating the proliferation of rogue internet sites that unlawfully dispense controlled substances over the internet. And it's actually been very successful. I mean, the overall effect of the Ryan Haight Act has been very successful, and which is, probably why the DEA has been so resistant to making the changes that would potentially allow people providing telemedicine to do so. And I would agree with both the other speakers. I mean, I've had multiple discussions with the DEA over the years. The American Telemedicine Association has, sent many letters. We've had many meetings. We've actually provided the correct legal language to the DEA and to a variety of other groups to actually put in the waiver that would allow psychiatrists and addiction specialists to prescribe opiates over video or prescribe recovery medications over video. But still nothing has happened. And but the end result at the moment is, that certainly I take the same approach that John does, in that I simply advise people not to prescribe controlled substances over telemedicine. Currently, the only way you can really do it legally is if you actually also see people in person at least once every 2 years. So we basically don't go in that direction either, which is really tragic because there's such a huge need. But history is an interesting thing, and this has all come out of actually quite an effective law, and it has been an unintended consequence. So Anne, what do you think about the current legislation? Where's it going to go? What are we going to find?
Oh, if I could make $1 million if I knew exactly, but I'll give you my best estimates because we do a lot of talking to people to try to figure that out. So there was, as many people heard, it was impossible to follow. There were many bills that were introduced in the House and the Senate. What the House did is that they consolidated all of these bills under one bill. It's known as the Support Act. HR 6 is the number. And it had a number of provisions in it that are relative to the conversation that we're talking about right now. In particular, this forcing the hand of DEA to put out the regulations as part of it. It also instructs CMS to evaluate the utilization of telehealth services to treat substance use disorders. So basically, CMS, as most people probably know on this, is the agency that oversees Medicare and then regulates Medicaid and contributes to Medicaid as well, though we know that's also a state issue. But so that's a good sign. It also has an interesting provision. We haven't really talked a lot about EHRs, but it also talks about promoting incentives for EHRs because that's obviously a critical component when you talk about collaborative care and you talk about being able to treat people across the system to have that connectivity. So I think that's also important. There are also a number of provisions related to solving some of the insurance parity issues that we're going to talk about in the next slide. But so that's in the House. The Senate has some similar provisions in their bills. There's right now there's 2 bills, Combat and Heal. They are earlier in the process. Those bills have not been reported out of committee to be given floor vote time. And so that's a challenge. That's the next step on that side, is that they need to go to the House floor, or excuse me, the Senate floor. The Senate needs to vote on that, and then since we're fairly certain that they won't be the same legislative language, they'll go to what's known as a conference committee, where the House and Senate have to reconcile their differences in these bills, and then that conference committee bill will then go back to each chamber, the House and the Senate, and be voted on, and then it goes to the president. So just to understand, we are at the ending a legislative calendar year, which means that if we don't get this bill passed by the time they adjourn at the end of the year, we have to start the process all over again. So we're working very hard to get people to push for pressure to make sure that these bills get passed, and that the conference committee reconciles, and that the bills are voted on and it gets sent to the president before the end of the year. Because of the many things that the Senate has going on right now, particularly appropriations bills, as well as the Supreme Court nomination process, as well as political playing and volleying for the elections that are happening in November. It's unlikely, we think, that the Senate will take up the legislation before the election in November, and so then we're really looking at a lame duck session to get the bill passed. The good news is there's strong bipartisan support to have some sort of opioid legislation passed, but it's just a matter of the particulars on some of these issues that are going to be sticking points if they don't start working really now in a pre-conference way to reconcile the differences. So it's really important for people who really believe in this and want to see it passed that they contact their member of Congress to do that. And we have a tool on our website at opioidrecovery.org that can help people do that and find their members of Congress. So that's kind of a broad overview about where we're at right now with the legislation that could help advance some of these issues and break down the barriers.
So, Anne, that's really helpful. I mean, can I ask you a question from a personal perspective? I mean, when I lived overseas until about 2004, I used to regularly prescribe methadone as a general psychiatrist to patients with opiate use disorders, and I would just treat them myself with, whatever appropriate other team members. Obviously, that's not possible in this country, and methadone, despite the evidence being strong for its effectiveness, is essentially only can only be prescribed in state programs. Is there any move to try and open that up more?
Yes, actually, there are. Well, one is there's a lot of bias specifically against methadone because when it was first really used in the States, there was some abuse issues that caused it to be almost overcorrected, regulated, where you could only go to these OTP programs where you had to go every day and get the methadone. But there is in some of the in 14 states, Medicaid doesn't even cover methadone. So one of the things that the bill would do, for that HR 6 bill, is extend Medicaid coverage to those 14 states, as well as, and Medicare doesn't cover OTP programs at all. So if you are on Medicare, you can get opioids and you can get methadone for pain relief, but you cannot get it for recovery medication. And that's one of our big issues right now, is that's the height of just hypocrisy and prejudice against people with opioid use disorder. But there is actually recently there was an article, I think it was in JAMA, maybe it was the New England Journal of Medicine. It was an opinion piece by the former drug czar and a number of other influencers talking about expanding access to methadone through primary care doctors. There's quite a bit of consternation about that idea among people who really, the OTP programs do a really great job of servicing the patients. They have a approach that includes counseling. There's a lot of these programs have other social support opportunities, associated with them. So they're very highly regulated. But we believe that there is opportunity to expand access to methadone through other places. I've heard about a state that's trying to get a waiver to do mobile methadone clinics. So these types of opportunities, I think, could really open up access to methadone, which is a very important drug, as you know, especially for people who are, on heroin and have been doing this for a very, very long time. Methadone may be the only recovery medication that works for them initially.
Right. All right. Well, look, that's very helpful, and certainly all of those, methadone clearly could be prescribed over telemedicine without any particular problem, certainly from a clinical perspective. So if we could just move on to the last slide about insurance barriers, and Anne, I think this is again your area of expertise, but John, I'm not going to miss out on you as well. But we'll start with Anne.
I'll be real high level here. I mean, parity is a huge issue for mental health in general, and it's certainly one of our big pillars to talk about. It's historically, mental health parity just has not existed. Insurers are not covering mental health services like they're covering regular services. In fact, a recent study last November was released by Milliman, and it showed that in 2015, behavioral health care was 4 to 6 times more likely to be provided by out-of-network providers. The reimbursement rates for these therapies and for these services are so low, and that in the networks are so limited that a lot of times you have to go out of network, which is much more expensive to get your care if you can find a provider in general, as we've seen about the capacity issues. Insurers. This study also found that insurers pay primary care providers 20% more for the same types of care as they pay for addiction and mental health care. In states like New Jersey, they found that 45% of office visits for behavioral health care were out of network, and this figure was as high as 65 or 63% in Washington, D.C. So, and I've already talked about the insurance barriers for methadone. Isn't covered by Medicare. It's not covered in 15 states. Buprenorphine and naltrexone are not adequately covered. They have things like dosage limits, duration limits. Many people are on methadone for multiple years, but in some cases there are programs that limit you for 1 year or 2 years of methadone and put a cap on that. Dosage limits are often very, very low when they need to be much higher in order to be effective. So these are all discriminatory insurance practices that can be resolved if they would enforce the parity laws and look at some of these issues.
Okay, well, thanks very much, Anne. It's all a bit depressing, isn't it?
Yeah, it is.
Having said that, John, you're at the practical end of this. We're going to have to finish in about 1 minute. So, John,
Sure.
I'm going to pass on to you and for any final comments.
Well, very well said, Anne, and I certainly would add to that in regards to even Medicare continues to limit the use of telepsychiatry based on their perceived shortage areas. We've not seen anywhere that there's not a shortage, and I can tell you, having had to manage a outpatient public clinic for 2 decades, we lost money every single month on the psychiatric portion of our clinic and had to struggle to make it up in other areas with grants, doing large amounts of therapy and begging for tax dollars. So historically and continually, the rate for psychiatric care is inadequate and unsustainable. And however, with that, there's a lot of evidence to demonstrate that timely access to care on outpatient, again, improves outcomes and actually lowers the overall cost of care. So I don't know why we can't get traction on this. I think it might have to do with stigma, but would certainly advocate that this needs to move forward. And again, I just leave it with Dr. Yellowlees and CHQI. Thank you for the opportunity to join you on this. I think hopefully it's been very productive for the audience.
Good, and if I can both thank you, John, and you, Anne, as well. This has been a really interesting discussion. Just to very briefly sum up, I mean, I think our conclusions overall is that telemedicine certainly should be able to be used for treating people with opiate use disorder. It's not currently being used to any substantial extent. And there are still substantial regulatory and insurance barriers, all of which are entirely artificial. And so we would strongly encourage everyone on the call to sort of get involved in trying to have some of these regulations gradually altered, and we look forward to being able to treat more and more patients in future using telemedicine. If I could just also finally finish and thank CHQI very much for this. And you'll see on the last slide there information about CHQI, and please do use Twitter and LinkedIn to connect.
Thank you so much, Peter. Thank you so much, Anne. Thank you so much, John. Thank you to everyone for attending today's webinar. We certainly hope that this discussion provided some valuable insight into the role telemedicine can play in combating the opioid epidemic. In case you missed any previous CHQI webinars, we invite you to visit our website, chqi.com, navigate to the webinar page located in the resources section. If you have any questions following the presentation, please feel free to email them to info@chqi.com, and we will address them promptly. We are also happy to put you in touch with any of our expert presenters today as well. Again, thank you so much for attending, and have a great afternoon. Take care.